Hi, I am Francesco Mintrone and I would like to introduce you the immediate tooth replacement, a really nice technique that can be used in a really nice way. We can obtain really nice success, and we will see some review, some article and a lot of cases, and I will try to give you my experience. I will give you all the information that I normally use to plan these cases, and we will see together the important result that we can obtain with this technique. I want to show you this case. For me, this case is really nice. This was a stride case for me, so there was a fracture and the case in the deep of the root. I decided to contour my future restoration, so there were also the opportunity to have some kind of little recession. So we know from the paper of Coyce that if the free gingival margin is more coronal comparing what we will have in the future, it's perfect for us. Right now I want to show you the video of how normally I make these kind of cases. So just to understand the idea of this kind of treatment. Look at here. Normally I'm going to make an evaluation about the dimension and the future restoration. You have to probe to understand if there is a bone over there. Just because we know if the bone is not there, according to what we know, we cannot use this kind of technique. And then with the blade, sometime a microblade or a normal blade, a 15C, we can make a desepitalization of the sulcus and then a gentle extraction. We have to avoid to press again in the buccal direction, because we have to avoid the extraction of this tissue in the bone there. We have to clean a little bit just to avoid any kind of tissue inside there. And here, look at here. Right now I'm checking exactly where I will start with my precision drill. Because the osteotomy will be done exactly in the palatal side, as I told you, just to avoid any kind of contact. But look at here, especially with the second camera, we can understand how we can get in the palatal side, and then we can change the direction of the drill just to obtain a really nice insertion. And then from there, it's really important for us to check if the position is right, everything is done, and then we can go with the sequence of the drill that we use normally, considering to maintain exactly the axis. The axis that we decided before, so it's not the axis of the root that was there before. So we are on the palatal side right now. It depends of the quality of the bone. Sometimes we have the need to under-prepare, because if we make a normal preparation, we can lose some kind of some stability. And so under-prepare, it means obtain with the same torque, even if our implant, especially in the buccal side, is not in the bone. Look at here. Right now it's possible to see, for example, where the axis of the root was and where the axis of my implant is right now. And then we can start to place our implant in a normal way and trying to maintain the axis. Sometimes we can start from the buccal side because normally we use aggressive implant, corkscrew shape implant, and so implant that can maintain a really good stability in the bone and can achieve a really good stability. And so we can get in and then we can move a little bit just to create the perfect axis of our implant. And then it's important to calculate exactly the position of the neck of the implant. We know that must be not too deep, so not too over 2.5 or 3 millimeter from the future free gingival margin, as you can see here, and no contact at all. And right now what we have to do, we have to check the stability. As you can see here, we were over 35 Newton, and right now we have to use this bovine bone just to fill the jumping distance. So this for me was a really nice case to do, precise. I try to compact this bios inside the gap just to avoid any kind of contraction of the volume, especially in the buccal side. And so with a fine instrument, I try to compact, avoiding the contact with the surface of the implant, and then I try to do everything gentle, in a gentle way. And then what we have to do? We have to create our in this case I decided to avoid the final abutment at the time of the surgery, and I create a provisional restoration with a titanium temporary abutment. For me, it's mandatory to avoid the plastic temporary abutment in these cases. And right now I'm trying my temporary, and then using some flowable composite, I normally fix my restoration in the right position, and then as I showed you before, I finish this restoration, the provisional restoration, as outside of the mouth, never inside, because if you start to put any kind of resin, you can leave some reminiscence over there, some kind of contamination of our graft, and in some way it's not the perfect way to do that. And look at here, after the fixation, I'm going to take it out, and then I'm going to refine and then place in the mouth. And look at here, this was after the surgery, no any kind of incision, anything, and this was the X-ray after the extraction. So the position was good, everything was nice, and I tried to under contour the buccal side. So right now, sometime everything can go in the wrong direction. Everything was done rightly as you saw, but look at here, 4 months later, the papilla level is perfect. The free gingival margin is around the same place where it was before, but look at here. Look from the buccal side, from the occlusal side. The view can show us, can demonstrate some kind of recession where the buccal volume is. It's gone. And so probably even if, as in the case that we saw before, for example, in the study of Myron Nevins, that even if we use bios, we can have also some in little percentage of the cases, we can have some recession. Also here we had recession. So probably we can do something more to maintain this level. So for me, this is not a really nice case. So for me right now, there is the need to do something more just to make, for example, a connective tissue graft. For this reason, I want to show this other case where, for example, also here was a straight case, an internal resorption, the tooth was for sure an oplet tooth, and so the free gingival margin was perfect just to start with the surgery. And look at here, the technique was the same. I am jumping a little bit the first phases, but look at here. Right now, I'm trying to add my material inside the jumping distance as we done before. But what we can do to maintain the level? For example, we can add in the beginning some connective tissue graft. And the connective tissue graft can come, from example, from the palatal side or from the tuberosity, and we can make this connective tissue graft with a tunnel procedure. And as you can see here, we can make the tunnel in the distal, in the mesial part. Sometimes we can pass also in the buccal side, just to take care to avoid the fenestration of the tissue, and we can fish inside this tunnel our tissue. And with only 2 sutures, we are able to fix our graft. And then in this case, this was my final abutment at the time of the surgery. I am removing the excess of the connective tissue graft just before, and then placing my temporary, provisional restoration. About the provisional restoration, it's really important to know that if we are going to work with the final abutment at the time of the surgery, probably we can go with the cemented, because the cementation will be really around the soft tissue margin and not really deep. And if we use the temporary abutment, we normally make a screw retained restoration. And look at here. Right now, it's really important to see 4 months later. Right now, we are in a good condition here. Probably the tissue in the buccal side, it's too bulky. It's too much. But for me, it's a really nice condition where to start from. Because with this provisional restoration, I will try to push a little bit the margin just to improve the free gingival margin comparing to the other central incisor. And look at here, the preparation of the veneers also in the other central incisor, and in the distal area, just to improve the zenith, there was the need to prepare the slight preparation of the distal part of this final abutment. And this was my impression. And look in here, before and after. For me, this is a nice result. Probably there was the need to just be really critical to move the free gingival margin more in the apical direction, because we are too coronal comparing the other central incisor, but I have to say that it's a really quite nice result consider this kind of technique. So right now I want to finish with this video with some concept of the immediate tooth replacement. Thanks for your attention. Bye.
For more education programs, visit the GIDE Institute at www.guidedental.com.